everyone, and thanks for tuning in to our first dialogue as part of our series on the future of resilient health systems. We're going to tackle a really important question today, and one which is actually rapidly rising in importance in the context of COVID-19. And that's, what is community care, and why is community health important for the future? My name is Ivana Gazabara, and I'm the host of today's conversation. In my day-to-day, I lead the Future Center, which is a participatory digital platform for tracking trends and signals of change, making sense of what's emerging, and broadly building communities to drive positive change across key sustainability challenges. So I'm very lucky today in that I'm joined by four amazing thinkers, each of who works actively on an aspect of community health. And I'm going to let each of them introduce themselves and just say a few words about their work. They also got a small bit of homework ahead of the conversation, which was to choose an image which to them personally exemplifies the community health system of the future. So I'm also going to ask each of you to share your image when you introduce yourselves and tell us why you chose that particular one. So Diana, can I start with you?
Thanks, Ivana. Hi, everyone. I'm very thrilled to be joining this very important conversation. My name is Diana Nambatya Nsubuga. I work for Living Goods as the Africa Regional Deputy Director in charge of policy and advocacy. And in this role, I oversee advocacy, policy engagement on the continent. But also beyond that, I really support Africa CDC as they're thinking about their PACT initiative, which is the Partnership for Accelerating COVID-19 Testing on the Continent. I chose this image because it really speaks about what communities are like. Communities are interconnected. They oftentimes sit together and have dialogues to make informed decisions. But beyond that, they have building blocks set up together that on a day-to-day basis, they are communicating, they are facing challenges together, finding solutions together, and really making sure that they are living together in an ecosystem. And so this particular diagram really brings out that theme in this.
I'm also absolutely thrilled to be involved in a conversation like this with such great thinkers. It's a real privilege. And I'm particularly pleased about the exam question because I think it is one of the big considerations, particularly after the pandemic. But as to us, so I'm Chief Executive of a charity called Mental Health UK, which is essentially a collaboration of 4 charities within the 4 different nations of the UK. We've worked for a number of years with Johnson & Johnson to begin to try to, I guess, fulfill our core purpose, which is to model a different kind of healthcare that recognises that in mental health, all of the other factors which combine to either improve or alternatively deteriorate somebody's mental health need to be brought to bear if people are going to live successful lives and flourish in terms of their mental health, something, of course, that we all have. And the reason to that end that I chose this picture, a bit like Diane, actually, I think that communities are interconnected, and I think we see that here. I also think it is the sum of the parts, which is really important in terms of community care, because precisely because people's lives are connected, different organisations and different people stepping in to support one another is at the core of what constitutes good care. And I guess finally, being an optimist, I tend to think that the future is brighter than the present. So you'll note that these people are staring into the sun. I hope they've got some good sunglasses on, but that's why I chose that image.
Thanks, Ivana. So my name is Madeline Ballard, and I'm currently the Executive Director of the Community Health Impact Coalition, which is a collective action network of health delivery organizations in 40 different countries who are working together to ensure that community health workers get the fair pay, the supplies, and the ongoing training that they need to ensure that everyone can have access to high quality healthcare. And I'm also an assistant professor at the Icahn School of Medicine at Mount Sinai. And as we look at this image, I just want to share 2 quick facts with you. The first is that 2/3 of community health workers on the African continent are women, and 3/4 of community health workers on the African continent go unpaid. And so the future needs to be one where these essential workers are fully integrated into public health systems. And that's what you see here. You see a community health worker who's being paid a fair wage, who has the equipment and the protection necessary to safely serve his community, who's being vaccinated as part of the first wave of healthcare providers, unlike so many of his colleagues who are not recognized in this way presently. So in order to achieve universal health coverage and have that strong community-based care delivery, I think we need to seek new opportunity in an old idea, and that's labor rights.
That's fascinating, isn't it? There's some facts already for our first Horizon discussion, which we're going to get to in a second. Ben, can I ask you to say a few words?
Sure, and hi everyone. Really honored to be here with all of you today. My name is Ben Davis. I lead global community impact for Europe, Middle East, and Africa for Johnson & Johnson, which also has an oversight role for the J&J Foundation in the region. And in addition to that, have a global coordinating role for our Center for Health Worker Innovation, which effectively is really focusing in on universal health coverage and looking at the gap between community care and primary care, and especially, taking the prism of the frontline health workers, because we know that there's a huge gap, obviously. 2 billion people don't have access to quality health services. 400 million people have no access at all. And, to be able to fill that gap, there's a huge need. I think it's 18 million health workers, as recorded by the WHO. So a huge challenge, but also a huge opportunity. And my image is slightly more abstract, actually. Maybe based a little bit on recency bias, but this obviously shows, the kind of a heat map of COVID-19, or at least I assume it is. And what struck me about this was really the fact that, to be able to look into the future, you need to understand the past. So I think this is, a huge warning in terms of, were health systems ready for COVID-19? Yes or no? If they were ready, what had they done well? If they were not ready, as we've seen in many cases, what could be done differently? I think we're at such a unique time at the moment to be able to listen, learn, and rethink and reimagine what the future could potentially look like. And as we've seen over the last, 18 months or so, these kind of the lines of connection, there's a global health system, but each of these health systems are very much, in their local context. And I think that is something we have to understand. And from each of those contexts, we can learn so much. So what are the examples that we can see in this global health system that we can really look at as examples for learning and for moving the work that we want to do, as a collective in this space on community health, moving forward. So
great. So I'm going to kick us off in a second, but before I do that, I just need to cover off a few logistical points that are going to make this conversation make a bit more sense to the audience. So the first thing is to introduce the 3 Horizons framework, which we're using to kind of structure the conversation today. And essentially, it's just a framework for thinking about the future and thinking about transformation more broadly. And you can see it here on the screen. The x-axis on the framework tracks time, the y-axis tracks prevalence. And so if you look at that framework, the first horizon that you see there is what we call the status quo today. So we're going to use that as the first part of our conversation today to describe the current context and conditions of community care around the world, our working assumptions about that, basically the dominant paradigm. And necessarily, not all of the ideas and practices and concepts on the first horizon are fit for the future, which is why you see that first horizon curve down as time goes by. So the first horizon is essentially where we're talking about what's dominant today, but also about what could very well decline across a longer term time horizon. And then we're going to move to the third horizon. And that horizon really describes the future that we want. So it is, in other words, our visioning horizon in today's conversation. And the seeds of that future are very much present and visible today in that, they are what we often describe as new trends and emerging innovations. So in the future, therefore, the third horizon hopefully replaces the first horizon. But perhaps the most relevant and interesting horizon for us today is the second horizon, actually, because that's the space of disruptive innovation, of new ways of being and doing that we see already, and essentially that space of change between the first horizon and the third horizon. So this is where, in our conversation, we're going to be asking the question of what do we need to do to kind of bridge from the status quo today to our preferred future on Horizon 3. So that's just a quick introduction into the framework that we're going to structure the flow of the conversation around. The second thing to mention is that Miro board that you saw earlier. So that's just like an online whiteboard. We've got one for this series of dialogues, and each time that we host one of these, we're going to capture the insights across the three horizons, allowing us to kind of visually categorize how people are diagnosing the status quo today, but also what you as the leaders in this field are articulating as the vision for a better community care system. And also what people think, I guess, are the key leverage points for transformation that's going to help us create the bridge between the first and the third horizons. So it's kind of an analysis tool for this dialogue series, but equally we're going to embed it on the Future Center page and open it up for all of our audiences and community members to sort of comment on through the discussion boards. So it's also a kind of participatory tool for ideas exchange. So just to note that before we start. So I want to start by also acknowledging the fact that community health is one of those concepts that I think not everyone understands fully, and also perhaps not everyone understands in the same way. So to just take the headline question of the conversation, I'd love to get a few views on this from some of you. What is community health?
I'd be happy to try first. I'm conscious that everything I say will be from a fairly UK perspective, and in some respects, the UK is in a position of advantage. We have a well-embedded healthcare system, is a relatively wealthy nation. But I would say also to some extent we have some disadvantages in that we are the kind of burden of disease, the kind of population growth and so on means that we have a health system that's creaking at the edges. But I mean, I think in terms of what constitutes community health, it's a very simplistic level. It's the recognition that most people live their lives not in the health system, not in hospitals or in general practitioner surgeries, but day-to-day managing their conditions, managing their good health and their bad health. And the role of good community health, or if you like, the effective good community health, is that people are able to access the different kinds of support, which may not kind of initially look like classical healthcare in the sense that they're not medicines, they're not diagnoses, they're not treatment regimes. But what they do ultimately is preserve and protect their health, their mental health, their physical health in the long term. I think that's how I would see community mental health.
Brilliant. Yeah, I really like that about most people not living their lives in the healthcare system. I think that's so true. Anna, do you want to give us a perspective from the field?
When we're thinking about community health, in addition to what Brian has said, for us, we're really looking at the physical and mental well-being of the people in a specific geographical region. And this very important subsection of public health includes initiatives that help community members maintain and improve their health. Usually, solutions are locally developed, locally made, and locally built up together in the ecosystem. But beyond that, residents look beyond themselves and take the collective responsibility to own their health. And we've seen over the years that communities that are attentive to public health really reduce inequality among the residents of the community. It also helps reduce gaps between the differences, be it race, be it ethnicity, be it location, be it social status, be it income, and among other facets of health. We've also seen that a lack of focus on community health can lead to a range of complex problems, not only beyond morbidity, that is like sickness, but also mortality, and beyond even mortality to a full entire broken community health system. So as people are thinking about the bigger blocks of health, if community health is not put in its right place, then there's entirely no health system that is functioning, because the smallest component as a community health system is not prioritized.
Fascinating, thank you. I like that kind of idea that it's so networked, and this is a nucleus of the system. Madeline, did you want to add in a perspective?
Yeah, I wanted to add on to what Brian and Diana were saying by zooming into some of the actors that participate in this health delivery. And I think, as Diana was saying, it can be mothers groups, it can be community committees. I think a catch-all term that folks might have heard during this pandemic is community health workers. So basically, your neighbors, lay people who've received some type of organized training to provide healthcare services in their communities. And as Brian said, that can be mental health. We also see that it can be promotive health or curative services. So everything from providing birth control injections to doing HIV care management. And while folks might have just been hearing about community health workers for the first time over this last year or two during COVID, I think it's also important to note that community health workers and community health at large is something that's been around for a long time, and that we've studied them a lot. Like Diana was saying, we know that when these workers are supported to deliver these critical services and reach folks that often aren't able for various reasons to get to a facility, or for whom management of their condition, be it weight loss or be it HIV or be it mental health, is better done in the community, that we ultimately see that the level of sickness in a population goes down and the number of deaths in a population goes down. And there's even some economic analysis that suggests that, when we make those investments, like Diana was saying, we can, for every $1 that we invest, we can yield a return of up to $10 through saving lives, through creating jobs. So it's really a big deal, but again, I think often something that doesn't get talked about a lot, and it's only in these recent times that the spotlight is on community health for obvious reasons.
Yeah, and I think to pick up on that, I think probably one of the challenges in the status quo, if you like, is that healthcare has been very kind of pillar focused, right, in terms of therapeutic area or disease specific, which doesn't always necessarily help build the capacity and capabilities, at that community level, in terms of looking at a broader resilience, resilience as an individual, as a family unit, as a community unit. And I think that has certainly come to be shown over the last 18 months or so, undoubtedly so. And I think that's probably also one of the larger criticisms also aimed at funders of such programs such as ourselves. And I think that is, major. I think that discussion has been going on for some time, but I think it's a real good wake-up call now to, really look at, and for us, it's very much, community health is the foundation of a health system, and what are the kind of connection points? Because I think, as Brian rightfully said, is that, you live in your community, right? And within that context, you're connected into the health system. And probably what we've seen in so many other geographies that we've been working in is that there's been a lot of programs that have been, kind of funder-led around disease-specific areas, which of course also, help, drive, improvements in that space, but not enough at the kind of horizontal level. certainly at the interconnection between community and primary care.
Yeah, that's a really, really fascinating insight. And I mean, I think that what you've both said is so true, that we've all seen it function in the last year or so in our own communities. And so it's now visible, but it's been around forever, as Madeline says. And we've been researching it as well. So then how does it look if you were to kind of describe the state of play today in community care? What's the dominant way of doing things? What's the kind of business as usual, the hallmarks of that system?
I'll plug in. Community health worker programs, particularly on the continent, as Madeline mentioned, have been in existence for many years. And unfortunately, community health cadres have not been integrated in the healthcare system. The way it operates is that the community trusts key people. Oftentimes, over 85% of community health workers are women, and the communities entrust them with their health. And so in the many years, the community health workers were not trained, they were not having curriculums. And over the years, Living Goods, many other partners working with ministries of health have supported them in developing curriculums that can enable community health workers to be trained. With those standardized curriculums, the community health workers have been equipped with knowledge, with skills in offering basic treatment of key diseases like malaria, diarrhea among children, pneumonia, among others. The spectrum of community health workers and their work is huge depending on what they're able to give. I remember Madeline mentioned HIV, malaria, and a number of others. So the spectrum is wide. But what we've seen over the years is that community health workers are the first cadre of health that a person in the community will be able to see to get a fast, quick diagnosis and immediate treatment to be able to get better, particularly on the continent where the distance between a mother or a child to the health post is approximately within 30 to 40 kilometers reach. And with the very bad terrain that many countries have on the continent, community health workers enable the mother access the service in real time. And then along the way, we learned that they cannot do it on their own. And so equipping community health workers with digital tools has also enabled them to be able to diagnose treatments, offer the medicines, and in cases where there are emergency situations or the patient is very sick, they are able to refer. So community health workers, beyond giving the first step of service, they're even a linkage to the bigger health system or health post or a clinic. Over time, we've also seen that the data was very critical. And so governments have taken on ways on how they can get that information through the DHIS tool. And so the community health worker will do the work, but the digital tools enable them feed in that information and then integrate it into the national system. There are still a number of challenges. In many African countries, you cannot be able to know who is this community health worker? Where is she? What was she trained in? What are the capacity gaps? And so currently, a number of countries are taking on community health worker registries, so that with just a click on a laptop, you can be able to know which area has community health workers trained on malaria or trained on HIV/AIDS, and what updates do they need. It is now time for us to advocate for rolling out of community health worker registries, Because once those are in place, we'll be able to understand this cadre. The compensation issue is a large one. Many community health workers on the continent are seen as volunteers. The WHO guidelines are very clear that VHTs or community health workers need to be compensated. And beyond being compensated, they also have to be enabled with key essential parts of medicines and supplies that they can get to the mother or the child at the last mile.
Yeah, I think what Diana's getting at is that we're living in a fractured landscape right now, where some community health workers are living in that future that all of us described. They're living in resilient health systems. They're fully integrated. They're equipped. They're supervised. They're ready and ultimately supported to provide critical care to their community. The vast majority of community health workers, and I would say like the dominant status quo, not just across the continent, but from various states in the United States to various provinces in Pakistan, are living in a status quo that looks really different, where they're recruited to go to some training without anyone having tested their qualifications. They receive a few days of non-assessed lectures. When the PowerPoint concludes, they're given some supplies, but those supplies quickly run out. They're told someone's going to come, provide coaching and meet them in their area, but nobody ever comes. And they receive maybe a new backpack, but that doesn't pay for food. And so across the world, we see that these community health workers who have so much potential and have shown repeatedly, again, over the past 100 years, what they can do when they are supported, are left unequipped, unsupervised, unpaid, and so they never do reach their potential. We don't treat them like professionals, and so, but we expect them to kind of perform like them. And I think that's the sad state of where we're at. And what Diana was describing is glimmers of pockets where that future is that present is being rewritten, and hopefully there's a vanguard for where we might go in the future. I know I'm mixing the horizons, but this is where we are. It's not neat.
Yeah, no, that is how these conversations go. That makes a lot of sense. And do you think that, so open question, because things are changing so much as a result of COVID, and because the role of community care in managing a pandemic like this is really foregrounded at the moment, are you seeing things shifting, or are we learning something new about the functioning of community healthcare in this context?
Yeah, I think it's a really good question, because in a way, if we'd been having this conversation 18 months ago, then I don't think we'd be thinking about community, or at least we wouldn't have tested the proposition of community mental health in the way that it has been tested. And I dare say that it's been tested very differently in very different parts of the world, depending on how established the healthcare systems are and to what extent a kind of primary care or a secondary care system interacts well with a community care system. So I think the pandemic has really, if you like, changed the terms of the debate. And obviously, the pandemic has mostly been very bad, needless to say. But I think if there's an upside, it's the level of literacy at population level, that actually any health system that simply intervenes when people become unwell is a bit like the pandemic itself. And I think, Ben said earlier on, are the healthcare systems were they ready to meet the pandemic? And I think it's fair to say that virtually none of them were. I mean, some have done very well, but that's as much because of the political leadership in those countries, I think. But ultimately, I guess the thing that's happened is that we probably have all begun to recognize that a healthcare system that is only intervening when people become unwell is intervening very expensively, because actually you're then having to catch up. And much better, really, to think about those other areas and domains of people's lives, again, which will be very different in different parts of the world, but fundamentally share a few similarities. Do you have, are you isolated in your community, or are you in a good friendship circle? Do you have access to work? Are you paid sufficiently well that you're not running into debt? And therefore, do you have access to good quality food? Is your physical health good in terms of the effect it has on your mental health, that relationship between the two? And also, do you have reasonable prospects for employment? All those things I think are fairly common in people's lives. And any healthcare system that doesn't think about those things is likely to see not only the, if you like, the disease burden increasing amongst its population, but it's finding itself intervening very late, very expensively. And when a pandemic comes along, lo and behold, actually it isn't equipped to deal with it. And I think there is a correlation between countries where there is a good community mental health system and good outcomes.
I think also there is a slightly greater recognition that health and health systems do not stand alone or separate from, for example, what's happening within climate change, and certainly also from the economy. I mean, that has been this constant balance at all times between closing down your economy and opening it up. So how do you balance public health with your economy, right? And I think what we've seen here in many instances is, a lot of pressure on social determinants of health because of increasing inequalities, because maybe not having access to a job anymore. I see also across Europe in particular, I don't know the global figures as yet, but you see the number of school children who have performed less good statistically than previous years because of homeschooling or having access. So I think, there's this rising level of inequality, which is also affecting, I think, access to care and access to health, because those who have availability of looking at it from a private, health perspective can access and others not. So, and I think that's probably between countries, but also within countries, that we're seeing that rise in inequalities for sure. And maybe the recognition around that, and then, the framework that we operate in around the SDGs, et cetera, that tries to bring a lot of these factors together. What I don't see at the moment is a sense of urgency. But hopefully that is something that can be picked up. I'm seeing it rising in climate change, but maybe there's an opportunity for us to look at here from a universal health coverage perspective as well.
And as you say, to look at the intersections between the two. Okay, so let me take you then into a more kind of visioning space, because so that's an interesting point about urgency also, because we are in the midst of this pandemic, right? And I can't believe I'm going to say this, but at some point it could end, or maybe not. But kind of in the future, what are we seeing? How big of an element of the overall healthcare system is community care? What does it look and feel like? What are kind of its hallmarks in a kind of ideal version of events?
That's a very important question, Ivana. COVID-19 has actually shown to governments that when they are looking at a health system, it's critical for them to put a lot of priority and focus on the community health system. When the lockdowns happened and a child fell sick, the community health worker in the lockdown was often the first person to identify, to treat, and if possible, to refer. No matter the health crisis, community health workers and volunteers are always the frontline health workers in the world, in the hardest to reach communities, who will spread the word. And they're so brave, hardworking men and women that reach the communities. Having said that, with this pandemic that we're in, governments are now putting the bar higher on community health workers. A number of governments have put in place, for the first time ever, community engagement strategies. And these community engagement strategies are really speaking to how will we have community health workers well positioned, not only for COVID-19, but for any other pandemics that might come in place. A number of partners including SHIC that Madeline leads, that convenes us as a number of players in community health, are thinking about guidance documents, particularly most recently, the WHO guiding document that really focuses on the role of community health workers in this pandemic is one that really pulls out how that is becoming very relevant. In terms of financing, I would say that we're not yet there, but over and beyond, we're seeing government starting this conversation to say, how do we budget for community health workers? A number of governments are putting in place community health strategies that are costed, that will guide them over the next couple of years, make sure that this key workforce is compensated, is supervised, is digitally enabled. But to mention that we know that this will not happen immediately. And there'll be very many challenges. But I think we need to continue these conversations to bring the governments on top of these conversations. The last bit I want to say is that community health workers have been very central, even in the COVID-19 vaccine program. They've been mobilizers, they've been educators, they've been trusted residents of these areas in preventing the spread of COVID-19, but also in dealing with the myths and misconceptions around the vaccine and making sure that as many people can show up for this vaccine. And I think it's now critical to push the conversation to equity in distribution of this vaccine, to make sure that these frontline health workers are not only vaccinated, but can play a very critical role in making sure that their communities also access the vaccine.
And I guess that's possibly the case with all kinds of vaccinations rather than just COVID vaccination, right? Brian, you were going to come. I was just about to say, Brian, give me your take on the kind of integration of physical and mental health as a part of an integrated model. What does that look like?
Well, I mean, I think you've anticipated me beautifully there, because I think one of the key pillars of what would constitute a good vision of community health is that the physical and the mental health component that we all experience in our lives is fully understood and responded to in a much more preventative fashion. Again, I think Ben talked about having a very pillar-focused approach. It's very often the case, and again, I speak from a UK perspective, but I know this is true in other countries, that it feels like the health system revolves around the health professionals, and it's the job of the individual, the patient or the consumer, to find their way around that. And I think particularly, this is true both in physical and mental health, but in particular, I think if you are experiencing a mental health problem, there's a good chance you're not going to have the capacity or the capability or the confidence to be able to navigate your way around those different forms of support that you need. Actually some work that we're doing with J&J is about developing a navigator concept that helps that person at that moment of low confidence or low capability to get the support that they need in their local community, whatever is happening in their lives. And I think, again, that for me feels like a sort of important principle into the future, that we're organising the community mental health care system around the person rather than around the professional. And by the way, I don't think that's the current system is particularly good for the professional either. I don't think you'll find many healthcare professionals who are enjoying the pressures that they are experiencing. It's particularly difficult at the moment. But as populations grow older, as more demands take place, I think they are looking for that more integrated support that we're beginning to develop. And then I suppose the other element for me is just the extent to which, when thinking about community mental health, we're not thinking about the kind of classic train for health provision that I described at the start, that you're going along to see your doctor and your doctor's providing you with medication, but actually we intervene very much upstream. We encourage people throughout their lives to make good decisions. I think with the advance of neuroscience, we're really learning the extent to which we're not very good at making good decisions about our healthcare. We're all, we all default to the wrong kind of position very often. I think the more that we can encourage people by default to make good decisions about their lives, because this isn't just about what the system does for people, it's about the decisions people make in their own life. The more in turn, I hope that will create mandates in different countries for the kind of national policies and local policies that give people the best chance to live productive, flourishing lives. And that could be things like transport, public spaces, et cetera, et cetera. So that's, I think, the vision that I would see for the future.
I think it's a really great point you make, Brian, in a sense that maybe, many of the types of roles or frontline health worker roles might not exist as yet, right? To be able to deal with, this kind of intersection to some extent between, what is that place between the individual and the health system? Is it your community? Is it something larger? It's probably, I think, to Madeline's point, 3 horizons coming together here, right? In a sense that, how do you navigate this complexity? And, moving towards coming back to the point around the resiliency and, looking at prevention vis-a-vis curative, really having the opportunity, I think, to kind of explore what that could look like. And I think absolutely right, the current structures there's a power dynamic there and a funding dynamic, which also needs to be looked at, coming back to the whole financing role here. How can we help inform best practices? How can we also look at new models of financing? Is there an additional role here for a private sector? Yes or no? Could that be, more around innovative financing? That could be looking not from a grant perspective, because that always is not the best way forward either from a sustainability angle, but could we be looking at impact bonds or all kinds of new mechanisms around that to be able to provide stronger resilience at community level. So probably more questions than answers, but at least some of those elements I would see as being fundamental to a future community health system.
I do think the other part of that, actually, just to pick up on that, is we're talking quite a lot about the what, but I think there is quite a big question about the who. And certainly it's the case in the UK that there are huge inequalities in terms of people accessing care and the care that people are receiving. And, again, I wouldn't want to speak for other countries around the world, but I think if you're talking about what is a genuinely high-functioning community healthcare system, it has to be much more equitable than it presently is. Because just as, if you take housing as a really good example, just to again give a very specific look at this, we kind of assume that when we talk about housing, that if you don't have a good quality home, then it's likely that your mental health will suffer, your physical health in due course will suffer. But I think it's even more complicated than that. In the UK, we have a really kind of, dare I say, kind of aggressive private housing system that people either get onto the rung of a ladder and advance and move up, and that means that people are left behind because there's a huge gap between supply and demand. And guess what happens if you get good access to a decent home in a nice area? Well, your children get to go to a better school. And what does that mean in time? That means they've probably got a chance of a better job, and in turn, what does that mean? Well, actually they get access to better healthcare. So there is something about thinking really radically about all of the choices that people are able to make or are not able to make. And I think, again, I think the issue of race has really come to the fore over the last year, and we have a very inequitable system in the UK in terms of race. So I think we have to really think very deeply about how the ingrained structures and power imbalances exacerbate those inequalities, because there will always be a huge gap if we don't do that.
Thank you, Brian. And I guess you mentioned housing. Another thing that kind of springs to mind actually is food and nutrition. We've kind of focused much more on traditional healthcare delivery in this conversation, But it occurs to me that the kind of future community health worker could, to step away from those pillars that Ben was describing earlier, they could deliver so much in terms of a kind of a spectrum of services that are more preventative than curative, from kind of nutritional education and support to kind of fitness education and support. I mean, I'm sort of making this up on the fly a little bit, but it definitely feels like the way that role shifts in the future could deliver so much more to communities in the way of kind of a holistic health perspective.
I think, Ivana, this is where Ben's points about history and verticalization are really relevant, because I think this is another place where the future is meeting the present and the past. If you look, I mean, in the 80s in Haiti, community health workers were providing food to HIV patients because they understood that you can't take HIV medications on an empty stomach. They're going to make you throw up. They're that intense. So if you want to cure HIV, you need to cure hunger. And if you want people to come to the clinic for checkups, you need to reach them with donkeys or fees for donkeys. And so I think there's long been this understanding of what are called the structural determinants of health, the things that are having to do with, transport, food, employment, housing, all these things that determine, that are not typically thought of as health, like you say, but determine whether you're healthy. And that community health workers or community health isn't just this sort of technocratic insertion into your life, but is a place where communities can mobilize around these issues, as Diana was saying. And I think what we've unfortunately seen, and this is what Ben was kind of alluding to, is that often when we go to finance community health, we look at it through such a narrow prism. We want to know how many TB patients did you enroll into care, not how many stayed, not how many got sick and couldn't take the medicine because they also were facing hunger issues or transport issues or whatever. We only want to know this one thing. And so we only fund this one thing. And so we approach these problems as if they're simple and as if they're linear, when in many ways, kind of like Brian was also saying, they're multidimensional. And again, I think there have been folks that have recognized this for a long time, and community organizations working in many places to provide this type of holistic wraparound care. But that's not a story that you can tell in an elevator in 30 seconds. And so it's not sexy, it's not innovative, and often as a consequence, whatever gets kind of scaled up from those models is a vastly reduced version of what they originally looked like. So again, I think there's lessons to be learned from the past that we can bring with us into the future. And that
Can I quickly come on the back of that, actually, because I think what Madeline, the point you've raised, I think is really relevant, because I think it's also that thing about intelligent policy making, isn't it? There was a really good example in Scotland, and I can say this as a Scot. I'm afraid to say that Scotland's got a pretty chronic problem with alcohol, and that is serious for reasons that I don't need to explain. And the Scottish government came up with a really clever measure a few years ago, where it imposed very, very punitive penalties for people who had even a tiny amount of alcohol found in their system when driving. So on the face of it, it was this kind of safety measure around driving and accidents. Now, of course, it wasn't really. It was a way to kind of prevent people getting incredibly drunk and getting in their car the next morning. And as a kind of consequence of it, of course, what it created was a new social norm where it became unacceptable to be drinking late into the evening. And I think that kind of role of, policy that policymakers have of putting into place measures that will change the behaviours of communities themselves, even if it's by sort of intelligent design, I think is something that we as advocates need to try to encourage our policymakers to do across the world.
So that is moving us a little bit into the second horizon already, which is, so let's just go there. How do you make this stuff happen? As Madeline's just pointed out, there's a lot of knowledge already and also some good practice, but it's not sexy as an elevator speech, and it might be hard to learn from. So, how do we scale and spread some of the seeds of the preferred future that we're talking about?
I can attempt first, from the hat that I wear, which is, on the funders side predominantly, which is, I think, all the points being made is that, this space in general is really complex with multiple actors in it. And I think, how do you remove ego from the equation in many ways? Ego being looking at ourselves here, in a sense that as a funder, I think the kind of philanthropic space, if I can call it that, has been very proprietary. And it kind of is in this kind of balanced space between what is genuine impact and what is reputation building, right? And when you have a proprietary type of relationship, which you could also argue is like a donor-recipient relationship, there's a power dynamic there which is not necessarily healthy. And I think confronting yourself with that and looking at how can you still play an important role, from a funder's perspective, but it's maybe less about the dollar amount and more about, the collective knowledge and capabilities we have as J&J or as J&J Foundation and many other private sector companies have, also brings in, the opportunity to play a more convening role and a catalytic role. And, some work that we have kicked off over the last, I would say, 2 years or so is to try and move towards, the more kind of collective impact approach and drive alliances, because those systems are so complex. And as all of you know here, and where we work together, is that each organization, has a role to play in those systems. And so how do you bring together, an alliance that can really tackle some of these multifaceted areas? And then the kind of existential question, which is, I think, Brian, you mentioned, there's the question on the what and the who, but there's a huge question for us on the how. And, what is the role existentially we should be playing in that? Is it as a convener? Do we create the space to have these conversations? How can we also help drive greater collaboration among implementing organizations? Because there is also a lot of competition in that space. So I think, and this is where you need to kind of connect into policy making, bringing together the mindset towards a more collective shift to come together to have more collective impact. And at the same time, try to feel comfortable about the role that you can play in that space. This still drives value, because if you don't bring value into this equation, why are you doing it? So I think for us, it's a really great learning opportunity at the moment. And, we're learning as we're going along, for sure, with plenty of successes, but failures too. It takes more time. I think that's probably the key takeaway from our perspective here. It takes more time to do more complex things. To Madeline's point, it's not that sexy. It's not that easy to when you're talking about, foundational work at community or primary care level. You need to navigate really well.
I wanted to add on to what Ben has said, and wanted to say that it's timely as we're thinking about universal health coverage, leaving no one behind. UHC will never be real without community health workers. And so really positioning community health workers, ensuring that they're digitally empowered, supervised, compensated, is not only the best thing to do, but it is the right thing to do. The second thing, and I know Ben spoke to this earlier on, is the point around financing. A long time, programs have been donor-driven, where donors are putting in the money. and government financing really going to roads, infrastructure, and other things. And so looking at the Paris Declaration, where governments need to own programs, we need to push country governments to finance community health worker programs as a key sustainability approach to health for all. 3 is the point around social participation. We need to look around the table and say, who is at the table and who is not at the table? How do we ensure that even community voices at key decision-making platforms, so that we sort of hear their priorities and are able to embed them in planning and budgeting processes of countries, regions, and global aspects that are happening. 4th is the intrinsic need for data. It's more than ever before important to have data for decision making. If we're to push our governments to finance, we will need that data about community health workers, data about the needs that they have, data about the huge health gap, so that we make the case to the governments, but also to the donors, and also to the partners. And lastly, speaking with one voice. I think the community health space in the past, the status quo that Ivana was talking about, every partner was speaking for themselves. Luckily enough, now we have the Community Health Impact Coalition, where we all come together, we sort of plan together, and speaking as one voice helps in alignment, helps in making sure that we're not duplicating efforts, helps in making sure that we're sort of putting all hands on deck to make sure that we move this agenda forward.
Your data point, Diana. So this has come up as a theme a few times in the conversation, the kind of role of data and how much it can help community healthcare kind of leapfrog in terms of its effectiveness. So I imagine there must be huge untapped data that community healthcare workers are privy to on a daily basis. How do you tap into that? How do you collect that? How do you use it to improve future health service delivery? Are there any kind of favorite innovations out there in this area where you're already seeing best practice that you would flag?
Great question, Ivana. So at Living Goods, we use a smart health app, and all community health workers are enabled or empowered with a smart phone. On this phone, there's that smart health app that they use as a tool to be able to feed in, to register the families that they support. One community health worker registers the number of families that they are going to be supporting. So instead of a community health worker having a book to be writing all this data, at Living Goods, we work with the government, be it in Kenya and in Uganda, where we have over 14,000 community health workers that are government owned. So we empower them with a smartphone. On this smartphone, they are able to register the families, diagnose, they are able to treat, and in case the condition is not in their jurisdiction of treatment, they'll be able to refer to the mother or the child or the family to the health post. Once all that is done, the community health worker is able to save all that data on a central repository. And then Living Goods works with the government of health, and all this data is submitted with the HMIS form that is Ministry of Health done. And once this data gets to the Ministry of Health, we work with the data clerks at the Ministry of Health to analyze all this data and support them with brainstorming, visualizations that can support community health, that can support key decision makers to make informed decisions. We have learned that having the hard copy pages is good, but it's time consuming, it's heavy, it's not transferable, and oftentimes it's a lot of work for the community health worker to feed in all the paper-based. And so the smart phone helps them with just a click to do so much and to be able to meet as many clients as possible. But beyond that, Madeline talked about the coaching and the support. With the smartphone, we are able to support the community health workers have a supervisor. And the supervisor, even at a remote station, is able to support the community health worker because in real time on a dashboard, they're able to see what a community health worker is doing. And so there's that remote supervision that happens. Lastly, in real time, the government can be able to access this data in real time. And so if there's a key decision to be made, it will happen because there's technology that is enabling that. Our future is to see more community health workers being empowered with technology to be able to serve communities better. Allow me to plug in with this COVID response. Community health workers have been able to share information through messages, through pictures, to fellow communities with the smartphone. Remember, with this lockdown, there was no access. And so technology has enabled the community health workers to continue serving their communities even amidst this. And the power of technology has been real through the COVID response.
Ivana, just to come back to your question, and I think everything that Diana said there was fantastic, and a lot of that I think relates to the situation in the UK. So I'll not kind of attempt to go back over that because Diana did that fantastic justice. But I suppose a couple of other principles for me in terms of if the paradigm shift is how do you move away from a kind of sickness service where you intervene too late and it's too expensive to how do you attend to the complexities of people's lives that may not look like traditional forms of healthcare, but which ultimately keep people healthy, if that's the shift. I think I'd come back to, in addition to the things that Dan and Ben said, three kind of key principles. So the first is partnerships, and I'm completely with Ben and how he talked about the relationship between the funder or the enabler and kind of delivery body. I think for a long time, there was a bit of a marriage of convenience where funder gives money, funder feels good about itself and can say, look, we've given some money to important cause. Important cause gets the money and goes away and does it and kind of tries to keep the funder at bay and, has little to do with them. And I think we're all learning that the expertise that we can bring to bear in working in true partnership, and I've been really proud of the partnership that we've had with J&J over the last number of years, means that we can have that multiplier effect. We can leverage in income, particularly in a system that's very big and you have a oozing behemoth in the national health system in the UK, and you can move in a far more agile fashion to try out a proof of concept to prove to the system because it can't do it because it's too kind of rigid. So I think that's the first thing, the partnerships and the nature of those partnerships. I think the second thing is place. These are all P's, by the way, I should have said that. I'm not doing my marketing very well here, but these are 3 P's. But place, increasingly, I think it's understood that so much of the care that you have in your life is about what happens in your local community. And there's something about how you map the local community assets, understand what's available, so that when you go to see your healthcare worker, whether that's in a GP surgery or wherever that happens to be, they can do what they need to do in the short period of time that they have, but they can make sure that they plug you into what's available in your support. And I think more to the point, the organizations that are big, like we are, for example, can embody a spirit of generous leadership, helping others who maybe don't have the resources that we've got to play their part in a more structured fashion in communities. And I think that does help bridge that who question that I talked about. But the last thing I think is, and which is arguably the most important, is none of this will happen if we don't bring the public with us, because it's the public, again, as Diana was saying, who create the mandate for change, you know, who will cause political leaders and others to invest in the healthcare system, be they traditional or community. So I think actually the thing I would disagree with is I think this stuff is sexy. I think that's the slow incremental change that happens through partnership and happens through working in local communities is sexy. But what we have to do is find creative ways to tell that story so that it gets to the ears of the public and politicians, so that we can see that exciting innovation that happens sometimes below the radar is how you make big systemic change. It's not through reorganizing systems and putting different structures in place. It's about that local creativity that builds upwards.
I think to add to that, if I may, it just brought to mind two points for me. One is around program design and rethinking program design. And for example, Brian, you know, in addition to Mental Health UK and J&J working together on the Mental Health Navigator program, we also have the Tavistock Institute, who are an independent kind of reviewer and assessor of the program. What is interesting about that is, of course, you know, there's always impact data in terms of how many mental health navigators were being trained, how many people are they reaching, but actually this is also looking at the model. And it's something we haven't done enough, I would say, is understanding models and are they beneficial, and how could you potentially scale if that's an opportunity? Because there's this whole kind of, you know, dissection of what the model could look like. And, you know, so there's a whole part of that learning journey, which is also extremely important beyond, you know, the impact that could be had there. And I think what you were saying about being under the radar, maybe if you think about, you know, if we're looking at program design that has a more bottom-up approach, less funder driven, how do you look at, you know, the potential areas of positive deviance of real local programs, you know, that are actually affecting change in the local community? That's not something we're tracking at the moment. It would be so interesting. I see, you know, a couple of programs in the education space that look at that see, you know, education outcomes for children through using positive deviance. Is that something we could potentially look at from a community health perspective? It'd be fascinating to kind of look at some of those cross-fertilization ideas.
Here's a positive deviant story from you, Ben, from the pandemic. So I think there's this understanding that community health sometimes as part of health systems or just social care is like window dressing. It's not essential. We can ignore it. And I think that's, many folks have long known that's not true. I think we have countries like in Rwanda, for example, half of malaria cases are treated by community health workers, where these services are really the backbone of how so many people access physical, mental care. And in the pandemic, one of the big risks that we see, and not just in COVID-19, but other previous pandemics, Ebola, swine flu, is that the disruption to sort of everyday health services can ultimately kill more people than whatever the disease is itself. And from around the world over this past year and a half, we've seen health service use has declined in so many countries, not by 20%, by 40%, by 50%, by huge amounts, but not everywhere. And I think to just kind of almost circle back to where we started with this fractured landscape, we've seen research come out of this pandemic that shows that where you have these health workers who are very innovatively being equipped, paid, and receiving coaching. I say innovatively a bit as a joke because, again, I wish it was rocket science. But I think to Brian's point, it's just the quiet, steady execution of nuts and bolts that tells the ultimately quite sexy story. And that's what's happened here, where you saw those health workers that had that training, supervision, pay, and whose equipment included that personal protective equipment that they needed, like masks and gloves, to provide services in their community, they actually maintained services throughout the entire pandemic. And so that's looking at 3 years of data, 27 districts, 4 different countries across a range of maternal and child health services. Those services were not disrupted. They reached the same number of women, children, same outcomes. And I think it's important because, to Brian, it is a great story. It's a really critical counter narrative to this prevailing discourse around pandemics and COVID, and we're all helpless and essential health deliveries is going to get disrupted. We expect it, we identify it, and maybe we even understand it as inevitable. And I think what this story, the story that's being told here in those places, those almost foci places of the future, is that disruptions aren't inevitable. We can have resilient health systems where we do that quiet, steady execution, where we've set up those partnerships, where we have that long-term funding, not the new latest financing instrument, but just consistent streams of money from domestically and internationally over long periods of time. We've set something up that can withstand one of the greatest threats that we've experienced globally in our times. I think that those are the types of stories that hopefully, like Ben says, we can track more, and like Brian says, we can amplify more.
Thank you, Madeline. That feels like a great kind of rounding out note on which to slowly wrap us up, actually. I'm sorry that we're nearly out of time, because this has been fascinating and rich and very unique in terms of the insights that you have brought. So thank you so much for that. I am struck by a few things, including this last point that Madeline made, which is that in our third horizon, when we did the visioning, actually, a lot of the points made were just about some quite basic things. And that might be encouraging, but, you know, we spoke about community healthcare workers and community healthcare being budgeted for, governments having strategies for around kind of community health. And, you know, this whole theme of kind of financing and just channeling more of the right kinds of funds into this space. But also I was really struck by this theme of, you know, community health right now is sort of limping along in many places and not very well integrated into the wider healthcare system, but actually so trusted by communities. And that is really, I feel, a key theme for me coming out of this discussion, because as Brian said, we all live in our communities. We don't live in health systems. And so, and I can't remember who made this point, Diana, I think it might've been you. It's like universal health care is not going to be possible if you don't make community health work as the kind of the nucleus of it all. So lots of other interesting things coming out, but I'm going to have to stop there, I think, in the interest of time. And I just, as a final thing, want to say, do tune in again next week for another fascinating conversation where we're going to pick some of these themes up again. And this time it's about how do we build health systems that are focused on positive health outcomes rather than treatment of disease, which was also a paradigm shift that we were explicitly articulating in this conversation. So thank you again to all of you for your really amazing insights. And please, to everybody else tuning in, do follow the project along on thefuturecenter.org. And I think that's a wrap.